from Pakistan, from Karachi. He's a graduate of Dow Medical College, one of the very well-known medical colleges in Pakistan and in Asia. Uh, he did his internal medicine in St. Joseph Hospital in Pontiac, Michigan, and then he went to Texas to the Baylor University College of Medicine, where he did gastroenterology training. He is certified by two different boards, but he specializes in liver diseases and also general gastroenterology. Uh, I met him. He's a regular uh, attendee of our Friday prayers, but
Would you like Mike or not?
so he's here every Friday. So I thought it'd be great to drag him on a Sunday night. So please welcome Dr. Syed Taslim, who's going to talk to us about colon cancer and its prevention.
Looks good.
Assalamu alaikum, everyone. Thank you so much, Dr. Singh, for the wonderful introduction. So the topic of today is colon cancer and its prevention, which basically is a very big topic, and I have tried my best to summarize it so that we can all be at the same page regarding the importance of this health dilemma that we are facing these days in the United States. So beginning with some introduction, I would cover briefly and also in some details about what is colon cancer, some facts about it, risk factors associated with it, why it is important to get screened, what are the different preventive measures that we can take, and also some briefly touching on the treatment modalities. So what is colon cancer? Number one is it is a cancer that arises in our colon. Now, colon is a large intestine. It is almost 5 feet in length, 10 centimeters longer in women, and composed of right and left portions. And the cancer can arise in any part of the colon. Over the recent years, it has been shown that it not necessarily arises primarily within the colon. It can also arise from somewhere else and can involve the colon as well, which we call metastases. And it basically comes from a precursor lesion. Now, that precursor lesion is called a polyp, which I will be touching on briefly, different types and what it is. But in general, it is a growth, excess growth of normal colon tissue. And when it goes unchecked, it increases in size, or over a period of years, it just turns into cancer. 1 in 3 adults will have polyps requiring polypectomy, meaning removal via colonoscopy, which is a very common procedure that we do almost 20, 30 procedures every day. So these polyps are very important for us, and it is very important for the patients to know the importance of it. And I will highlight what we see in the colonoscopy, what gives us an idea about which direction to go, because it has an ultimate impact on the life of the patient. So moving forward, a brief anatomy. If you see on the right side where it says cecum, I'm talking about the figure on your right side. It is basically the end of the right end of the colon, which is the extent, the ultimate extent of the colon. It goes all the way up till the left side where you see descending colon, which is the left side of the colon, and then bottom down, which is a pouching called the rectum. Over here. In the middle part, it says ileum, which is basically small intestine. Now, colon is very important. It performs a lot of functions. Majority of it is involved in absorption of water and different nutrients and formation of stool. And as you can see, it's a hollow kind of a muscular tube. It contracts, it relaxes and contracts and plays a very important function in our daily well-being. And also, it is heavily innervated by nerves. It has its own nervous system called the enteric nervous system. And that nervous system communicates with our brain. Commonly seen if we have an anxiety or any other stress level, some may feel like the urge to go to the bathroom and have diarrhea, abdominal pain. So it is very sensitive organ, and it responds to different levels of our emotional status, and also regular bowel movements are very important as well. So moving forward, this is a colon polyp. This outgrowth over here, if you see in the lumen, this is what we are after when we do a colonoscopy. This is an outgrowth within the wall of the colon. It is an abnormal tissue. And once it develops, it needs to be removed. And we do that with the help of our procedure called the colonoscopy, which I will briefly touch and explain what we do. There are different types of polyps. This is very important, and I will tell you why. Because there are certain polyps that are not cancerous, that don't generally develop into cancer. They may grow in size, cause some symptoms, and we can remove them. Among those which are not cancerous includes hamartomatous polyps, which are basically solitary lesions. Solitary lesions meaning if they arise, it's like either one, they will never arise in multiple forms. It's a growth of normal colonic tissue, and we see them, we remove them, there's a particular appearance to it. Now, it may be associated with a syndrome. Now, syndrome means like if a person has a genetic predisposition to form these type of polyps. That then becomes a problem because then they form like hundreds of these polyps and they have to be removed. And these syndromes, for example, Creutzfeldt syndrome or juvenile polyposis, they can become a very health burden economically and as well as on the patient's overall quality of life. Hyperplastic polyps, these are the most common type. When we see them, we know that okay, this is not cancerous. We rely on the size of them. If they're small, we remove them. If they are bigger, then we can take biopsies. They can be removed via colonoscopy as well as by surgery. But now with the advent of newer techniques, pretty much bigger size polyps, we can remove them with a colonoscopy and save person from a surgery. They generally arise in the left lower part of the colon. So the location is also even important because colon being 5 feet in length, it can have different types of polyps in different areas. So when we are evaluating as a gastroenterologist, we pay a very particular attention on which side of the colon we are. Because the site of the colon, if it's the right side or the left side, will determine what's going to be the final pathology of that lesion that we are seeing. Inflammatory pseudopolyps, they are, as the name indicates, inflammation means when there is irritation in the lining of the colon. Pseudopolyps mean it's not a true polyp, but it's a pseudopolyp. It's basically irritation of the lining of the colon that results in outgrowth of that tissue. And we commonly see that in very particular two inflammatory bowel diseases. One is ulcerative colitis and one is Crohn's. I would not bore you with the discussion into that pathologies because it's like a world in itself, but these are very common IBD, short form of inflammatory bowel diseases that we see. Now more and more arising in younger folks. And I've seen quite a bit of people in Ohio affected by this disease. Mucosal polyps are generally very small. They're generally less than 5 millimeter. 5 millimeter is our cutoff. If it is less than that or equal to it, is small. Advanced size that we assess is 10 millimeters. So if it's 10 millimeter or bigger, it is a big size polyp, and it has the high potential to develop into cancer ultimately. So mucosal polyps, they look similar to the normal mucosa. We see them, we remove them, and if we don't see them, doesn't matter. Never turns into cancer. It's just like reactive tissue. It can be left alone. Some mucosal polyps, by some mucosa means that it is arising deeper within the wall of the colon. So all these polyps I'm talking about are arising above the lining of the colon. We see them within the lumen because the colon is a hollow muscular tube. When we go in, it's like a 360-degree hollow muscular tube being evaluated by our lens in the colonoscope, which is 10 to 30 times magnified, so it gives us a very clear picture. So sometimes we see these dents within the wall of the colon that something is arising from deep beneath it, and it is causing pressure. And that pressure causes the lumen to narrow, and we see a growth, like a swelling. So those are submucosal polyps. Majority of them are benign, but if they are bigger than 2 centimeters, then they need to be taken out by surgery because they can turn into cancer. And leiomyomas and fibromas. Leiomyomas are arising within the supporting tissue within the wall of the colon. And fibromas is again a type of the supporting tissue within the wall of the colon that gives rise to these lesions. Now coming to the malignant potential. Now these polyps have malignant potential, particularly adenomatous polyps and serrated polyps. The adenomatous polyps, these are the type that arise from the left side of the colon majority of the time, and they can turn into cancer. They have a very particular appearance that we see in the colonoscopy when we are doing to have a pit pattern. We see the lining, and we know that, okay, this is the polyp that has to be removed. Either by colonoscopy, we do that, or with surgery if we are not able to do that. And a little description over there, I would like to just highlight the importance of a lot goes into the background of development of these type of lesions. It's not simple like irritation and it develops. No, like we all know that every cell, there are billions of cells in our human body, and there are only billions of cells in the colon. Every cell has its own particular genetic makeup. It has a chromosome, it has a genetic makeup. It has already been predestined what it is going to be normally. Then insults happen in the form of different risk factors that I will highlight to you, and that will develop, like alter the genetic makeup. It will cause an insult into the normal gene. Now, if we see in the adenomatous polyps, it says over here, mutations in APC and KRAS. These are checking genes, like they make sure that the cells develop normally and they function normally. And then due to a hit into, or mutation, and mutation is called an abnormality. Now that abnormality can be caused either by environmental factors, meaning something that we are causing to ourselves, and sometimes genetic factors which are beyond our control. Whatever the mutation cause may be, that mutation causes it to develop abnormality in the form of this tubular pathology or tubulovillous pathology, and that we can assess with the help of a colonoscopy, and we remove it. The pathologist reviews it, and lets us know that, okay, this is a type of the polyp you are encountering, because that will determine us how we have to survey them when it's going to be the repeat colonoscopy. So the whole set of guidelines have developed over the past 10 to 15 years with these new incidences of colon cancer that has led to ultimately change in the guidelines. And I will show it to you in the upcoming slides, some public awareness, things that have happened. Serrated polyps. These are a gastroenterologist's nightmare. They are very difficult to remove. They're flat. They are in the right side of the colon. So we begin our colonoscopy from the left side and we go all the way to the right side. So sometimes technical issues develop and they are flat, they're big, and they're very sort of like hiding beneath, the mucus or secretions. So they have to be washed and all those things to be clearly demarcated. Sometimes we have to lift them within the wall. So we use needles, injection materials to have them lift within the wall so that they can be adequately removed. They have to be removed because their genetic pathway is different. So if we can see that even within the types of the polyps, there are the different types of genetic involvement. In adenomatous polyps, there were mutation in the gene, but in serrated polyps, the mutation causes abnormality in the process of what we call a mismatch repair gene. Mismatch repair gene is a gene that is responsible for fixing the genetic insults that happen every second. So subhanAllah, we have like this whole enteric nervous system in this organ, which is in our abdominal cavity. And every cell has its own genetic makeup. It has its own genetic policeman, I would say, that makes sure that the genes and the DNA is normal every time. And that is called a mismatch repair gene. It fixes that genetic insults. If there is a mutation in that mismatch repair gene, it develops into cancer. Because now the things are happening uncontrolled. And it is an ugly looking cancer. And majority of the cancer, they arise in the right side of the colon. And that is because it is technically difficult, as I mentioned. And above all, they can hide, they cannot surface. So it is very important for us as gastroenterologists to watch out, and we do look at the right side of the colon twice. And now for guidelines, we have to take a look at it twice. So we take a look at it once, then we take a look at it twice. And I myself have been surprised multiple times that I did not see the lesion when I was in the right side of the colon, and I went in again and I see this huge polyp pop up from nowhere. So it's very important for us, and that's why we counsel the patients, educate them the importance of a good bowel preparation. That is a win-win situation if a patient does that. Because the hard part in the whole procedure is the colonoscopy preparation. It's not an easy procedure. It's a very hard procedure, especially on the patient, and it does not involve the patient himself, but the family members as well. So it's the hard part. But if it is done well, it leads to good results, and it saves the patient from cancer. So moving forward, this is in a nutshell. If we start from left to right, where it says normal. So this is how a normal lining of the colon looks like. And if you see, it's like a healthy, uniform mucosa. And then the central figure shows this outgrowth, which is a polyp. And ultimately, the extreme right, where it says carcinoma, is what it happens when it goes unchecked or missed by a gastroenterologist. And that's when, the all bets are off. It's kind of like, then depends on if it has spread out into different areas or not, if it is removable by surgery. For sure, it's surgery without any doubt. Very seldom we are able to see now and remove them. Now we have newer techniques. One is called endoscopic submucosal dissection, but it is done in bigger centers. It's not very commonly done in community GI practice, where we are able to remove certain cancers by colonoscopy. So save a person from surgery. The whole goal is to save them from undergoing surgery, saving the part of the colon. Because if this type of lesion, like we are seeing on the extreme right, where it says carcinoma, that not that only that section comes out, the whole part of that colon comes out. So you will hear the term like a right hemicolectomy, or total colectomy. So the surgeon has to remove the entire that segment. And it's cumbersome. It has its own kind of like implications. So some facts which I wanted to highlight over here. So it is a major health problem. It's the third most common cancer nowadays in the United States, and it is all across the board, all ethnicities. When they did this demographic study, it is the second most common leading cause of cancer-related death. So it is very important. It's number two. It's number second leading to cancer-related death. More than 135,000 people are diagnosed each year alone in the United States. And the major reason is because everyone is not getting screened. 1 in 3 adults between 50 and 75 years old, approximately 23 million people, are not getting tested as recommended for colorectal cancer. And that's why we see these huge numbers alone in the United States on an annual basis. So there was an initiative that was led by big societies in America. One is the American Cancer Society, one is the CDC, and one is the National Colorectal Cancer Roundtable, which is a conglomerate of the above two organizations. And they led an initiative that we have to get 80% of the people screened by 2018. We were able to achieve that goal somewhat, and then COVID came. Everything went back to zero. So we are trying to catch it up again, and we have done good progress, but still a lot of work needs to be done. So moving forward, screening with a colonoscopy can prevent colorectal cancer. And the way we do that, because we remove the precancerous polyps. So you are removing that lesion in the colon that can turn into cancer. So that is unique of this procedure, because unlike other screening tests, we remove it before it happened. Unlike other screening tests, you get screened like a mammogram or prostate exams. When you see the lesion, it is already malignant or benign or something like that. But with the colonoscopy, you can remove it even before it starts to develop into a malignant process. So that's why it's important for us to remove the polyps. Last year alone, more than 50,000 people in the United States that died of colorectal cancer. It's a pretty big number. And 50,000 people they died, and it's across different age groups. It's not only elderly people, no, it's different various age groups, because now we see a lot of young folks with colorectal cancer. And it's a very difficult conversation. It's not an easy conversation with the younger folks or even with any person who comes with for a screening, and then we find this colorectal cancer. And the reason was because due to some reason the patient did not get screened, and then ultimately we are meeting them at a point where we have found this cancer. So it's not an easy conversation. It has a lot of impact on patient, their loved ones, and on their health, economically as well. So the number of people who die from colorectal cancer could be reduced by an estimated 60%, more than 50% we can save lives, prevent them from developing colorectal cancer if by this simple colonoscopy screening. So if you take a look at the overall impact it creates, it saves them from cancer. And just the only hurdle is that of the preparation that goes into place. But I think it is worth it if it saves somebody from colorectal cancer. So what are the risk factors? Lifetime risk of colorectal cancer is 1 in 20, almost 5%. And this is like total general population, adjusting for everything like, age, demographics, it's around 5%. And the prevalence of advanced adenomas, advanced meaning either like large size polyps or pathology-wise, like I mentioned before in my previous slides, malignant type of polyps, it's more higher in men compared to women. Colorectal cancer is most common after 50, but it can occur at younger ages that we have seen very recently. And I will update you on the change in the guidelines now. Ethnic background and race, which are generally considered to be high risk for colorectal cancer, includes Alaskan Natives, Native Americans, African Americans, Hispanics, Jews of Eastern European descent. Overall, the studies so far that have looked at what type of race generally is more high risk for colon cancer, Asians, Central African people, they are not known to develop this type of cancer. Now, there's a caveat because not everybody over there gets tested or screened so aggressively like we do in these ethnic populations and in these areas. So it may be a little bit of a bias over there because we are screening so much, we are finding so much. And over there, where I'm from, Pakistan, I don't think there's a lot of aggressive screening methods. So of course, the incidence is low. So it's not like it is not common over there, it's just not getting screened enough. So it may be a bias. So we have to take that with a grain of salt. Moving forward, these are some high-risk factors for colon cancer. For example, if somebody has a personal or family history of cancer, and family history is important because if there is a first-degree relative, mom, dad, brother, sister, with colon cancer, that is positive family history. That changes the age of which anybody needs to get screened. Generally, the guidelines say that if you have a first-degree relative diagnosed with colon cancer at age younger than 60 years, then a person needs to get screened at age 40 or 10 years before the family member was diagnosed with colon cancer. And then the screening will be after every 5 years, not more than that. It's an aggressive, intensive protocol that we follow. If the age of the first degree relative was higher than 60 years, then you do that at 40 or 10 years before they were diagnosed, and then you do average risk screening, like you were screened with anybody without a family history of colon cancer. If there's a history of colorectal polyps, now these are not like simple benign polyps, but they have advanced polyps, because polyps are very common. Every colonoscopy we do, we find polyps, but not everybody has increased risk from that standpoint that their family members had colon polyps, they are at increased risk. But if they had advanced pathology risk, then they will know. They tell us that, yeah, my mom or my dad or my brother and sister had big size polyps, or they had polyps that required intensive screening. That tells us that, okay, this patient has increased family history of advanced polyps and they need to be monitored closely. Inherited forms of colorectal polyps or cancer, there are certain inherited forms, like a couple of them I mentioned, for example, juvenile polyposis or Peutz-Jeghers syndrome or familial adenomatous polyposis syndrome, which is called FAP. These are all genetic problems that can predispose a person to develop colorectal cancer if they have a family history of that. Inflammatory bowel disease, again, if they have a family history of inflammatory bowel disease, we screen them, we ask a lot of questions if they are developing or at risk for that. If a person has a history personally of inflammatory bowel disease that predisposes them to high risk for colon cancer. So we have to enroll them in very intensive colonoscopy protocol almost on a yearly basis to prevent the colorectal cancer from happening. Personal history of gynecological cancer like endometrial or ovarian cancer at age less than 50 years. If then they are at increased risk for colon cancer. Now, is it like sporadic just because of that, or sometimes we see that as a part of the syndrome, which is called Lynch syndrome. So those patients, especially women, they have increased risk of ovarian cancer, endometrial cancer, and also colon cancer. So it's important for us to screen them appropriately because the only one thing that has been proven to prevent colon cancer is adequate screening. That is the only thing we can do to prevent it from happening. What are modifiable risk factors? Something that we can do, which again fall into the category of prevention. Obesity. As we all know, it is, I would say, the mother of all problems. It leads to heart attacks, diabetes, fatty liver, advanced liver disease, all sorts of cancers, but also colon cancer. And active smoking, physical inactivity, diet, which is high in red meats, processed meats, and it's also because of the carcinogens that are generated when they're metabolized or cooked, and that can lead to that. Alcohol consumption and a diet which is very low in fiber, fruits, and vegetables. The reason being is the fruits and fiber and vegetables, they add to the formation of good bowel movements that maintains regular bowel movements. The person does not get constipated and all those things. That ultimately leads to irregular bowel habits and can develop into colon cancer. What are the symptoms? So the important thing to know is most early colorectal cancers produces no symptoms at all. That's why screening is very important because we see them and they have no symptoms, and sometimes we get surprised ourselves that we see an advanced lesion and that is developing into a cancer. Common symptoms that we look for or ask the patients are abdominal pain. And this is not general abdominal pain, it's very kind of non-specific type of way occurring on a more frequent basis, not particularly related to foods or anything like that. It also is majority of the time accompanied by some other symptoms like blood in stool, which is a very important and very high risk factor for us. Change in typical bowel habits, and patients are very intelligent. They know that there is a change, and it's change that is significant enough that catches their attention and they bring it to us. We see a lot of referrals to change in bowel habits. Not every time we find something, but I will say almost 4 to 5 times a month we find cancer as a cause of the change in bowel habits. Constipation, diarrhea, anemia is also very important. So blood in stool and anemia, I would say if I have to select, those are the red flags among all the symptoms, or those two are the top. Blood in stool and anemia. Weight loss unexplained, it's very important to rule out colorectal cancer. And loss of appetite, unexplained loss of appetite is also something that we get referrals for, and we schedule a colonoscopy or some other test to screen them for colon cancer. So these are some multi-society recommendations, and these are all preventive measures. This all is like for prevention. So tier 1 is the topmost thing, which is highly recommended. Colonoscopy every 10 years, or annual fecal immunochemical testing, which is a short form of FIT test. It's a test that can be done at home, and it's available even over the counter. So it involves application of a stool sample to a card, and that card has built-in antibodies against the blood. So if there's blood in the stool, the antibodies react to it, change the color, and that's a positive FIT test. The thing is, ultimately, if it is positive, it will lead to colonoscopy. And then the tier 2, if the person is not agreeing to the tier 1 test, or there is any other reason, insurance issue, logistical issues, patient preference, we talk about tier 2, which is the alternative test. Now that is a CT colonography every 5 years, which is an imaging test. It has been developed over the last few years or so. The problem with this is it can detect only big lesions but not the small polyps. It's not that great, but it can detect cancer, it can detect big lesions. Or we do the fit fecal DNA every 3 years, which is quite commonly, you must have heard the name, the Cologuard test. And it's done at home and you ship it out, they check it, if it is positive, that means that the patient needs a colonoscopy to make sure there is no cancer lesion. Then we have the newer ones coming up, which is capsule colonoscopy, not commonly done. It's still in the works of being tested and developed and being vetted as a good test for colorectal cancer. It is done every 5 years in big centers. And then something that is being developed right now is Septin9, which is not recommended commonly in community practice, but it's a blood test. And if it develops, it will be great because now then you can just have a blood test, and if somebody is found to be positive, then they can get a colonoscopy or next steps, depending upon the results. So cancer prevention test, colonoscopy, as I mentioned, is the gold standard to prevent it from happening. Why? Because it allows us to directly visualize within the colon, see the lesion, we can biopsy it, we can remove it, we can mark it. We always do what we call a tattoo placement if we see a cancer-type lesion, because that will help our surgeons to go there and remove it, and it makes their process easy. Because you can imagine opening up the belly and seeing a 5 feet length of colon in multiple angles. It's not a happy surgeon. So we help them in marking that lesion by placing a tattoo near that area so that they open it and they go laparoscopically. Now, majority of the surgeries are happening, or robotics, and they know where the marking is so they can easily locate it and they can remove the lesion. So colonoscopy helps us in that. We can even take a look at the lining to see if there's any colitis or any changes. So it's very good detailed diagnostic as well as therapeutic procedure. It is the only test that allows a biopsy or removal of a polyp, as I mentioned, and at the very same time it is identified. So the moment we see it, we can intervene on it. That's the beauty of it, is you don't have to wait or come on back or anything like that. We can act there right at that time and take care of it. So benefits, examines the entire colon. We do not even the entire colon, we go even into the small intestine. So it's a very detailed exam. Ability to remove polyps. It is done with now intravenous sedation. Initially, I think 10 years ago, there was patient discomfort was a big thing because people used to get cramping and pain and all those uncomfortable feelings. Some of them used to feel like, oh, I was not even sedated at all. So it was called an unsedated colonoscopy. But now with the advent of propofol and newer medications, it's very smooth. It's a quick, easy procedure for the patient. They fell asleep, they don't remember the procedure, they're very comfortable, and it's a quick in and out. And longest rescreening interval, it's almost like 10 years. There's no other colon cancer prevention test that has this type of rescreening interval. So it is, when we do that and it is a good prep, it's like a 10-year rescreening interval. It has some limitations though. Number one, like I said, it requires a prep, which is the hardest part from us and for the patient. Patients have to miss a day of work. They need a ride. They have to arrange all these things. So logistically, it is a burden. Unexpected events or complications are rare, but they do occur, and their occurrence is almost, I would say, 5%. So if this 5% is among hundreds and thousands of people, so it's very rare. It's a very safe procedure. Also depends upon the experience of the gastroenterologist who's doing the procedure. Missing a lesion is, I would say, the complication. Bleeding, infection, injury to the spleen, because the spleen is located on your left side of the abdomen, and due to maneuvering or stretching and pressure, it can cause injury, and that injury can be very painful. It doesn't happen very commonly, I would say less than 5%, and it is manageable. Perforation, it's a gastroenterologist's nightmare, like trauma to the wall of the colon that creates a hole, like poking a hole. And even in training, it's kind of like you're grilled in to watch out for this complication in particular. because it's surgery, leads to surgery if it happens, majority of the time. A bad reaction to the medication used for sedation. So patients did not tolerate anesthesia, develop a reaction. It could be an allergic reaction, it could be respiratory depression, or their blood pressure could not tolerate. They develop nausea or vomiting. So it's all sort of things. But we have majority of the practices now have a dedicated anesthesiology team that manages that portion, leaving the endoscopist to focus on their portion, which is the procedure by itself. Some alternate screening tests, which ultimately fall into the realm of prevention of colon cancer. So a lot of the people, they prefer annual FIT testing. It has to be done annually. It is collected yearly, detects hidden blood and stool, like I mentioned before. Then it is a card test. It has some antibodies to it, react against the hemoglobin present in the stool, and it changes color, and that's a positive FIT test. If positive, would need eventually a colonoscopy. Other tests, the Cologuard, which is called a fecal DNA test every 3 years, CT colonography every 5 years, and flexible sigmoidoscopy every 5 to 10 years. Flexible sigmoidoscopy is a shorter form of a colonoscopy. Previously, we used to go up till almost the left side of the colon because it's a shorter length, but now with the newer techniques and interventions, we can almost sometimes do a whole colonoscopy with this thin scope and complete the procedure. But if that is being used as a sole modality for colon cancer screening, it has to be done every 5 years, 5 to 10 years. So benefits of a FIT test: it does not require bowel preparation. Sampling is done at home. It is low cost, non-invasive. Limitations: it requires stool samples, so it's burdensome. Requires annual testing. It can miss polyps, and colonoscopy necessary if it is positive. So it is only detects the scarier part when it is there. It doesn't detect the small polyps, medium-sized polyps. This was a study by Park et al. Done in Korea, and they compared the two types of at-home tests. One is the FIT test that I mentioned, and one is another guaiac positive test, which basically another card test, but the stool specimen is placed on a particular type of paper. It's a chemical paper, it changes color if there's prints of blood. And the two circles that I mentioned were here in the red. You see that the polyp detection capability is low. The cancer detection capability is good, but the polyps are not that frequently being detected, and ultimately they will turn into cancer, so you have to undergo that annually. And still there are miss rates. So there's another, this comes in box, the fecal stool DNA test, which is called Cologuard, and the FIT test, it comes in this packing, is available, like I said, over the counter, and it can be done at home. So prevention, healthy lifestyle is the key. I think healthy lifestyle is the key to a lot of diseases these days. Liver diseases, heart diseases, diabetes, different forms of cancer, including colon cancer. Some things that we can do is decrease the fat content of the diet. Now, studies have shown Mediterranean diet, you can Google it up, it has different forms. It has shown very great results as a form of high fiber diet, which is very balanced in proteins and low bad fats, and also good balance between carbohydrates and stuff. It has now been used as a form in irritable bowel syndrome, which is, we primarily manage it with diet. It has also been used as a primary form of treatment in people who have fatty liver, because there's no one medicine for non-alcoholic fatty liver disease. We treat it with diet and exercise. So Mediterranean diet is something that we should look into and follow on a regular basis. So eat more foods that are high in fiber, including whole grains, fruits, and vegetables. More vegetables, including cabbage, broccoli, cauliflower, Brussels sprouts. Increase calcium intake, low-fat milk, shellfish. Fish is very good source, salmon, calcium supplements with vitamin D and folic acid. Being in the Midwest, I think everybody should be on calcium and vitamin D. We barely get any sunlight. So everybody is low in vitamin D that we have seen. So it's something that we should be on a regular basis. Limit the intake of charcoal broiled food. So what it means is there have been studies that show that people who frequently use barbecue items, charcoal-based barbecue items, so they're in that charring process, there is generation of aromatic polyhydrocarbons and other carcinogens in that process that can be carcinogenic. That doesn't mean that we should avoid altogether. It's just like we should not take it on a daily basis. Once in a while is okay. So kind of limiting that. I myself, I love barbecue. So it's not like it's something that you should avoid altogether, but it's something to keep in mind that if you use it not as frequently. Avoiding salt cured foods, processed foods also come into play, avoiding those. So going more for like organic produce, and those are fresh, and good for good health. Exercising regularly, avoiding smoking, and being in the normal BMI range is very important. And the main thing I would like to highlight is whatever we do for any sort of healthy living habit is going to affect the colon health, and it's going to affect all of the other health problems a person may be facing. So it's like one treatment fits all kind of methodology. So treatment briefly, it's divided into surgery, chemotherapy, radiation therapy, or targeted therapy. It depends on what stage the cancer is. It depends on how the pathology looks like. There are different things that go into play. When we remove a polyp, the pathologist tells us if it is involving the margins where we remove the polyp or not. So generally, if it's not involving the margin, then it is considered to be cured. If it is not involving deeper layers of the colon, then it does not require any aggressive monitoring or treatments. But so that's why screening comes in. If you catch it early, you can prevent it from invading into the wall of the colon and spreading out. There are certain chemotherapies that are oncologist friends they do. Some are called that they do before the surgery. It is called neoadjuvant. The term is called neoadjuvant, and some is done after the removal, which is called adjuvant chemotherapy. And that is to prevent it from recurring. The neoadjuvant that is done before the surgery is to reduce the size of that cancer. And then it makes it easier for the surgeon to remove it. And the one that is done after the surgery is to prevent it from recurring. So it can be curative in many cases if it is screened properly. So prevention is cure in a nutshell. Why should I get screened? So starting with a little bit brief history, average risk American population was recommended to get screening at 50 years in the past. Then in 2009, American College of Gastroenterology issued new guidelines recommending that African American patients should start screening at 45 rather than 50 because there was an increasing incidence of colon cancer in those individuals. Then in 2018, American Cancer Society recommended all patients undergo colon cancer screening at age 45 because the incidence was dramatically going up, and it was not caring for which ethnic background a person belongs to. Ultimately, in 2020, the United States Preventive Task Force adopted the Cancer Society guidelines, and now we are screening at age 45. That is the new biggest change in guideline. So 45 is the new 50. So we start screening at 45 now. Why African Americans be screened early? So they have high incidence of colorectal cancer. They have a high propensity to develop lesions in the right side of the colon. Again, the right side of the colon is where lesions are hard, they hide, and they turn majority of them into cancer. We also call that proximal colon. And the distal one is the one that is on the left side of the colon. They have increased incidence of developing cancer at a younger age compared to other ethnic groups. And African Americans with colorectal cancer have decreased survival compared with other ethnic groups. So this is a well-known fact that did not change. But now the change was the rise in the colon cancer was seen kind of involving other ethnic groups that led to change in the age being 45 for colon cancer screening compared to 50. So younger people, American Cancer Society showed that Americans in their 20s and 30s are being diagnosed with colorectal cancer. We are in community practice seeing a lot of those. Adults born around 1990 have double the risk of colon cancer and 4 times the risk of rectal cancer, which is the very bottom end of the colon, compared to adults born around 1950. A lot of studies were done, debates about why is this happening. We don't have an exact cause, but some of the potential causes that were suggested was lack of early screening, unhealthy diets now being more processed foods, red meats, low fiber intakes, Smoking and alcohol intake increase incidence of that, obesity, sedentary lifestyle. So these were thought to be contributing. So why take chances is the question. So, like I mentioned, colorectal cancer is something that can be prevented just by screening, unlike other screening exams, which are important, but the main difference is colonoscopy or any other modality for colorectal cancer screening can prevent it from happening if done accurately. It is the second most common leading cause of death related to cancer, and third most common cause overall. And more than 50,000 people are expected to die from colorectal cancer this year. So screening can save half of that if they get appropriately screened. This is some public awareness thing. It's called the Couric effect. So Katie Couric, she was a co-host of the Today Show, and her husband, Jay Monahan, got diagnosed with colon cancer in 1997, and he died in 1998. She underwent colonoscopy on live television 2 years after his passing to create awareness, and it led to an impact on the common, general population. If you see this arrow, it led to an increased incidence of colonoscopies being happening. It was termed as the Couric effect. The same thing happened with another actress called Angelina Jolie. I mean, she had a bilateral mastectomy after that, and they saw an impact on increasing mammograms. So good work was done by these folks, and they wanted to make aware of the general population. And it led to, at least for 1 year, 1.5 years after this Couric did her colonoscopy and raised this campaign of awareness, it led to increased colonoscopies. We also have annual colon cancer awareness month. March is the colon cancer awareness month. All of the gastroenterologists, they have to wear blue. We take part in marathons, awareness programs, and all those things. So we do these campaigns, and it leads to good results. So I think we need to do more of those awareness programs and campaigns. Chadwick Boseman, I think everybody knows that, the Black Panther guy. Born in 1977, he died in 2020. Was diagnosed with colon cancer stage 3, not even stage 4. So it had not spread. It was still limited. But the burden of that cancer process was such that he passed away at an early age of 43 years. And I think that when that happened, along with the different data that was coming in, the guideline was changed, and it became at 45 years. So take-home points is, again, colon cancer is the second leading cause of cancer-related deaths, and is highly preventable. I mentioned it in red and irritating slant over there. That's to make it highlight that it is highly preventable. Colonoscopy is the gold standard for colorectal cancer screening. Now we start screening at 45 years, at age 45 years, and increased incidence of colon and rectal cancer in adults less than 55 years. And the best screening overall is the one that gets done. So whatever a person commits to should follow through that. So the best screening test is the one that gets done, be it the colonoscopy, annual FIT testing, the Cologuard test, or the CT colonography test. And with that, I would like to conclude. These are some of the references I use. These are our society guidelines, and they are accessible free for everyone. The acg.org, the gastro.org, asg.org. There are a lot of information for the common general population to increase awareness as well. So thank you. And I'll make
Would you like to have some questions?
Yes, please. We'll take if anybody has any questions. Please.
You have another mic?
I'll talk loud.
We can take this one.
Do you know, is there an increased incidence in people who are gluten intolerant, or that's it, primarily? Gluten intolerant or celiac disease?
That's a very good question. There's no increased risk of colon cancer in those particular pathology. We see a very high population of celiac disease in our general practice. Majority of the time they're younger. I have seen some elderly gentlemen and women too with celiac. So no increased incidence or relation to colon cancer per se. Now, I would say that celiac disease by itself, it has some association occurring in parallel with inflammatory bowel disease. People who have Crohn's or ulcerative colitis, sometimes they have up to 10%, they have associated celiac disease as well. So now that if that is there, that will increase the risk of colon cancer, but not celiac disease per se. It is an immune-mediated problem to gluten, and people follow a gluten-related, gluten restriction diet, and they do generally well. If left unturned, it can turn into, like, if it becomes aggressive, which has different parts like type 1 and type 2, it can form lymphoma. Now, lymphoma could be of the intestine, of the small intestine in particular. So yes, that can happen, but not of the large intestine, not for the primary colon cancer.
Thank you.
Yes, brother.
People that, let's say they have heartburn and they're taking Eprazole, are there any effects, does that fuel colon cancer, like Eprazole or any other medications out there?
Are you referring to the medication itself?
Yes.
Yes, so omeprazole by itself has shown to form certain polyps, which are called fungal polyps. These are benign polyps, and they appear because omeprazole by itself inhibits the acid production. And when it inhibits the acid production, the stomach has a whole lining of different type of cells. So the stomach produces acid. It produces liters of acid every day. And when you take omeprazole, it inhibits those pumps from producing the acid. But then there's a feedback mechanism within the stomach itself. It says, hey, why are you not producing acid? It stimulates the cells. So those cells, they are inhibited by the omeprazole to not produce the acid, so they grow, they proliferate because they are not able to meet the demands of increased acid. So they can form some polyps, they become bigger. Polyps mean those are gastric polyps, or those are benign. They generally don't turn into cancer. If we see those polyps, the term commonly seen is fungal gland polyps. So these are normal lining cell polyps within the stomach. If we see them, we can remove them, especially if the size is 1 centimeter or 2.
Any other medication than Eprazole?
Not generally. Omeprazole is the one that is very commonly used, Prilosec, available over the counter, and it doesn't even happen like over weeks. It takes years. Like somebody's on it for like 6 years or 10 years or something, and undergoes an upper endoscopy for some reason. We may see polyps in that, which is called fungal gland polyps. Generally, it does not cause any symptoms, and even if you look at the packet label of omeprazole, if you're buying it, it doesn't even say any relation to cancer or anything. It may form polyps, yes, but not cancer. And those polyps, if we see them, if they're 1 centimeter or bigger, we can remove them. But if they're less, we leave it alone.
Any other questions or comments?
Only you say you must in age.
I'm sorry, can you repeat the question?
Okay. How late can you,
How late?
Study the
Age,
policy.
age-wise.
Up till 80 years.
after 80?
Up till 80 years. So the general recommendations in average risk people who do not have any family history of colon cancer, who are doing regular up-to-date their colonoscopies. And by up-to-date meaning you can miss like, a 1 and 2, but if you have like 2 or 3 previous colonoscopies, and so we stop screening at 75 years. Right? Somebody is 75 years, we stop it because we know that they are up-to-date with their previous colonoscopies, nothing cancerous was found. If they do have a history of family history, for example, or they have a history of like a big polyp removed or something related to that, if they have a history of colon cancer, we can continue till 80 years. Because above 75 years, the risk versus benefit ratio kind of changes towards more higher risk compared to benefit from colonoscopy. So we stop it at general population, to answer your question, at 75 years, but we can go up till 80 years.
So you're doing this thing because you know that after 80, they have a limited longevity. Why to waste time on them? Why to waste resources on them? Is that part of the equation?
We just say, okay, just enjoy your life. It's only 8 years. It's like a counseling that I do to my liver patient that I say, eat a low-fat diet and the person is 85, 90 years, and they're like, are you kidding me? He's like, I'm 90 years old. Just leave me alone. I came here because my family brought me. It's hard to negotiate at that point. It's like, high fiber diet and stuff, but the risk of anesthesia, so the studies have shown the risk of sedation, the risk of medication itself, the procedure-related complications, meaning trauma to the colon and all those things, that risk goes up as well. So that's why we say that, okay, the risk is too high compared to the benefit if you see a benign polyp or something like that. Generally, it takes years for it to become into cancer. It doesn't turn into cancer right away. That's why we say 10 years, yeah. So that's why we stop at like 8.
Have you invented a colon prep which is more palatable?
So yes, that is.
By the way,
I didn't get the
oh,
question.
I'll get to it. All of you have had experience with colonoscopy.
Yes.
And anyone who says no, I think is about time. But do you know how the prep is? I mean, the cure is worse than the disease. You have to drink a gallon of fluid, and it's the most unappetizing. So, what's the new advances?
So it's like the pill form just came out.
Yeah.
A lot of studies were done actually, and I totally agree with you. It tastes like soap water. One of the person I asked, oh, why did you not drink the prep? I want to understand. He was like, it tastes like soap water. You want to try it? I was like, no, I don't want to try it. So that's what the Go Lightly is the commonly one that we use, the 4 gallon. But now there are smaller volume preps by the name of Sue Prep. It's smaller volume. It comes in kits. And the biggest advancement that came out was pill form. It's called Sucat. But the main thing is those pills, there are 2 bottles. Each has 12 pills each. So you have to take the 12 pills at one time. And you have to take it with enough water, enough fluid to get that good effect and clean out. And then you have to take another session after a few hours. But still, some people prefer the pill form rather than the whole 4 liters. And now we use that, even that 4 liter Go Lightly, you use it in a split method, right? You use 2 liters and 2 liters. So it gives them a break. You can have it over ice. You can have it over with clear drink of your choice, like Sprite, 7-Up, ginger ale. Keep on sipping. So it makes it a little more palatable. But the pill form is the best.
When was the last time you had that?
I have not yet had. Pretty soon, yes.
He's too young.
Getting there. Getting there.
So I'm just saying this thing, sip that, unless you've gone through it.
I've just researched it and communicated it so many
Okay.
times that
Okay.
it seems like I haven't done one. But
The aftermath, once the procedure's done,
yes,
there's that that sensation, that uncomfortable
Yes.
glutation, what do you call it?
bloating and
The bloating.
cramping. Yes, it's a very important question. Yes, so it was all of the paradigm. To answer your question, it was all of the paradigm that was studied because people complain about the cramps. People complain about I'm awake during the colonoscopy. I'm feeling pressure. I'm feeling pain. All of these things led to a huge debate and research, and then we developed low volume preps. The whole goal was to number one develop low volume preps and other to make the procedure comfortable. So in that paradigm, conscious sedation, good office sedation came into picture with the propofol. So it makes the procedure very comfortable. Patients are totally asleep. They're not awake. They're in, you can say, deep sleep. They don't remember a thing. And the moment they wake up, it's like, okay, the procedure is done, despite the fact you spent like an hour. They don't realize that it is being monitored. And number 2 is we use carbon dioxide, CO2, in our procedure. So the main reason why anybody would get a cramping was air, because we were using air to inflate the colon, to make it, to navigate through it. And that air has nowhere to escape. So it only comes out from the bottom and it stays there, it stretches the colon, creates horrible cramping. People end up coming to the ER because they thought that they have undergone a perforation. So now we changed, now we use CO2, carbon dioxide. So carbon dioxide, the benefit is it dissipates into the blood. It doesn't cause the bloating, it doesn't cause the stretching, and we use a lot of water. So water immersion technique is new in the game now. All of us,
Excuse me, you use a lot of water during
the
colonoscopy to inject water in the colon,
Yes.
along with carbon dioxide.
Yes, it's a combination.
And we could request that procedure, right? So if I'm going through that, I could request that new CO2.
Oh, yeah, you can ask them that, okay, do you guys use air or CO2? In our newer colonoscopes, the 190 that we use, I think it's pretty much very common. We have that dual option. So we can use CO2, we can use air. We all use CO2 by default, majority of the gastroenterologists, and we use a lot of water. So our colonoscope has channels in it. So one is the lens, one is the water irrigator, and one is the instrument channel, which is also used for air and CO2.
One more thing.
Yeah.
So I learned that from you. Now, as far as the sedation,
Yes.
there's you mentioned it earlier, the best sedation.
Propofol. Yes. It's
That's
yeah.
the best technique right now.
Yep, that's but it is a little dangerous. If you recall, it killed Michael Jackson. Well, he was using it to sleep every day. It's not like to be used like that, but it is a powerful sedative, and it kind of patient goes into becomes asleep within a few 20 seconds, and they wake up 20 seconds. As soon as the anesthesiologist monitors it, they have an entire team, and they, based on the weight of the patient and age and stuff, they give a certain amount. And once the procedure is done, by the time they're in recovery, they're already alert and awake. They're having a meal or having a juice and stuff, and we talk. So it's changed quite a bit.
Yeah. Fadi, next time you go to Costco, buy some CO2 and take it with you.
So I have a couple of questions about perforations.
Yes.
Number one, can the lining of the colon be so thin that a perforation would happen, or is it usually caused by too much pressure on the scope or something? Number two, can a perforation happen and the doctor not realize that it perforated? I
Yes.
can't, okay.
Those are very important questions. And like I said, these are the ones that keep gastroenterologists awake at night. The right side of the colon is thin walled, and the left side of the colon is a little bit thicker wall. So thin wall meaning it is more riskier to perforate in that section of the colon. Yes. It can withstand certain pressure because it is a muscular tube. It has the capacity to stretch. So it can become bigger up till a certain extent, but not excess pressure. So yes, that's why when I was mentioning in the right side of the colon, its extent is far enough. The lesions hide, they're bigger, and they're more prone to turn into cancer. So that's why we take a look twice in the right side of the colon. And it has a more propensity to perforate. So that's why we always, whenever we see a flat colon, we raise it from the lining. So we inject material into the lining, which is called a lifting agent. And that lifting agent changes the color, makes it more prominent, and it raises it up. So that creates a cushion between the very deep lining, after which, if it goes deep enough, it can perforate. So that cushion helps us remove it without the risk of perforating it. Plus, we put clips on them, so we can close the defect that we create. So these are certain preventive measures that we use. We use heat. We can use heat as well if it's a big colon to prevent it from bleeding or closing. So that's to your question number one. Yes, the right colon is in particular thin wall, and it is easier to perforate there. Now, coming to the part that sometimes we don't realize, yes, it can happen, particularly in the sigmoid colon. Sigmoid colon is the very left lower side of the colon because it is shaped in the form of an S. So it's really navigating curvy. With age, it can have some scarring over there. It can become very hard, fixed in the pelvis. And then someone can develop like pockets in their colon from chronic constipation, which we call diverticulum. And those pockets, they develop due to pressure of the stool. That's why we say a high fiber diet to prevent those from happening. And those pockets are simply dense within the colon wall. They don't do anything. They don't turn into cancer, but they can bleed. They can become infected. And that's where perforation can happen with us even realizing it. The most common, they did a big study and they found that the most common reason to perforate, where the doctor did not realize, finished the procedure, patient went home, just developed unrelenting pain. And that's why we always give discharge instructions to the patient that, okay, if you have unrelenting pain, which is not going away, or you develop a lot of like bleeding, you have to come to the ER because perforation can happen without us realizing at that point. It just does not surface at that point. It kind of it clears itself as the regular function returns. So that's where we worry about. So we use water immersion technique, carbon dioxide technique to prevent those from happening. They help us do the colon. Air can be very problematic, and pressure and all those things.
Well, thank you so much. I think this was so enlightening. So on a happy note, I heard that in the Soviet Union, they used to do tonsillectomies through a colonoscope. And the reason is that in that society, people were not, they were not allowed to open their mouths. So they used colonoscope to remove tonsils. Well, thank you very much. It was a very enlightening presentation.
Easy to understand. Yes.
So I think it's a Zohar time. Fadi, would you do the honors, sir?